Managing Physician Group Practices, Health Science 375, presented by Kendra Anderson, Jill Christensen, John Friedman, Amanda Galton, Stephanie Morley, Alicia Pledger, Kristen Smith, and Diana Wilson. As defined by the Medical Group Management Association, a medical group practice is a formal affiliation of 3 or more physicians who share income, expenses, facilities, equipment, and support staff.
For the historical perspective, in 1883, the first physician group practice was formed when Charles and William Mayo joined their father's practice in Rochester, Minnesota. Their practice later became the Mayo Clinic. In 1908, Harry J. Harwick was hired by the Mayo Clinic. He was one of the first medical group practice administrators and later helped found the MGMA. In 1926, the first annual conference of clinical managers was held. It has been held annually since then and is now called the MGMA Annual Conference. In 1929, the Mayo Clinic had 386 physicians and dentists. These professionals, who trained at Mayo, spread throughout the country, opening their own group practices. In 1932, there were roughly 125 group practices in the U.S. About 1/3 of these were in the Midwest. In 1998, the body of knowledge for practice management was developed. What led to the development of group practices? First, there was increased medical specialization. Second, new drugs became available. And third, growth in technology. Because of these reasons, one doctor was no longer able to give all the care the patient needed. The doctors felt like they could provide better care by bringing different specialties together and diagnostic services into one place. What attracts physicians to practice in groups? As a group, physicians can achieve economies of scale, gain improved purchasing power with vendors, and gain leverage in negotiations with health insurance plans. What are the responsibilities of physicians in a group practice? Physicians in a medical group practice must participate in sharing patient care and on-call duties, helping colleagues when asked, abiding by majority opinions, participating in clinical governance, and recognizing that revenues and other resources will be distributed in some equitable way among the partners.
Size of group practices in the U.S. There are approximately 230,187 physician practices in the United States. Among these physician practices, 52.8% consist of only one office-based physician. The remaining 47.2% of physician practices are group practices. Physician group practices with 2 to 5 physicians make up 37.1% of physician offices in the United States. 6.3% consist of 6 to 9 physicians, and the remaining 3.7% consist of 10 or more physicians. In recent years, many small or solo practitioners have come or are considering coming together to form large, same, or multi-specialty groups in order to get a leg up on managed care.
The organizational structure of physician group practices varies considerably depending upon the size. It can involve as little as a few employees to hundreds or even thousands of employees in large group practices. The clinical staff includes physicians, physician assistants, nurse practitioners, registered nurses, licensed practical nurses, nurse midwives, medical assistants, and care coordinators, but also may include dentists, pharmacists, and pharmacy technicians. Clinical staff carry out medical care, health education, referral management, medication management, and follow-up. The administration staff provides supportive services to the clinical staff and to the practice. The services they provide include management, finance, billing, human resources, health information technology, regulatory reporting, business development, marketing, risk management, and quality improvement. In small practices, employees may have multiple responsibilities. The practice manager may need to work as part of the front desk staff. Many small practices will need to outsource things such as health information technologies or develop skills to address the upkeep of their technology.
Large organizations are normally managed by a board of directors. The board may consist of staff physicians, retired physicians, and community leaders, and essential personnel. For smaller organizations, the practicing physician or physicians would be the head. All employees should understand the hierarchy of their organization and understand the chain of command for accountability, and follow the chain of command for issues and questions which arise. A typical workflow for clinical tasks. A common workflow for tasks performed by clinicians would be patient check-in, office visits by type, prescribing and refilling prescriptions, scheduling appointments, creating lab orders, managing lab results, creating referrals, and discharging patients from the office. Typical administration workflow of services. The front office usually does the scheduling for appointments, verifying insurances, overseeing patient paperwork, reporting for patient arrival to clinical staff, and collecting copays. The billing department takes care of the coding, claim creation submission, denials and rejections of claims, posting payments from insurances, patient statements, patient payables, account receivables, insurance receivables, and collections. Take it away, Amanda.
Avoiding negative reimbursement issues. To avoid negative reimbursement issues, it is important that your facility has only one fee schedule. Discounts can be given to self-pay patients who are paying at the same time of service, but fees should not be lower than the Medicare allowable for such services. If discounted below Medicare allowable, it could jeopardize your current Medicare allowable fee and cause them to be reduced. Co-pays or deductibles can be waived for financial hardship cases, but it should not be a regular practice. Doing so can be viewed as a breach of contract. Keeping track of denials for CPT codes can help your reimbursement flow. If there are consistent denials, the coder may need to seek instructions from the insurance company to submit claims correctly. There may have been a new rule in place. Most physician offices will submit electronic claims through a clearinghouse. By correcting rejections and resubmitting claims, a disruption in payment can be minimized. Nonprofit practices vary in size from single physician to larger practices with more than 10 physicians. Nonprofit practices must have a board of directors to provide oversight for the financial operations and management. They usually focus on a particular group of patients in a geographical area. Such examples are low-income communities or special needs populations such as geriatrics. If the nonprofit is part of the federally qualified health centers or rural health centers, they are required to provide reporting to the federal government and have yearly audits of services performed. If the nonprofit is part of the FQHC or the RHC, they can receive grants from the federal government and increased reimbursement rates to expand care.
A day in the life of a practice administrator. We had the privilege to interview Carolyn and Kylo Kohlberg, practice administrator for the Vein Institute of Utah. We asked Carolyn what she found to be her major responsibilities as a practice administrator. She broke down her responsibilities into the following 6 categories: staff management, coordination of health services, facility management, financial management, marketing, and strategic planning. Practice administrator responsibilities, staff management. Carolyn responded, her responsibilities vary day to day, and at times I'm organizing coverage for staff and physician schedules, hiring and disciplinary responsibilities, conflict resolution, and staff team building. Coordination of health sciences and compliance. One of my major concerns is making sure that our patients have a positive experience and ensuring that they receive the best medical care. To accomplish this, I must review our systems related to front office procedures, nursing staff procedures, as well as physician performance. I am responsible to make sure that we are following all current mandates, including HIPAA, STARC, as well as any other current contracting or legislation. Staying up to date on changes can be difficult, and I find it beneficial to be active in my local MGM networking lunches and conferences. Facility management. Our clinic is physician-owned and operated, and we are located inside of our own building, and the responsibilities for overseeing maintenance, build-outs, city coding, and anything pertaining to the property. This is also keeping equipment, maintenance, and calibration scheduling up to date, and researching and purchasing of new equipment, whether it be specific to the building or medical equipment. Financial management. This includes responsibilities as simple as paying bills, payroll, but also includes compensation schedules for physicians, budgets, profit and loss, reconciling of bank statements. The most significant part of my job is monthly production reports that include accounts receivables and audits of insurance payments. Marketing. Marketing of the practice can make or break even the best physician's practice. Social media pages, blogs, emails, newsletters, and mailings. Networking with other providers' offices to increase referrals is a must and is really where we receive most of our new patients. Some of our most successful marketing has been appearances on local talk shows and even women's events. Strategic planning. Looking ahead and knowing your practice and physician's goals are a must for a successful practice and business. Forecasting legislative or CMS changes, contract negotiations, physician recruitment are just a few things that need to be continually be thinking about. When we asked Carolyn, what are your challenges as a practice administrator? She responded, managing physicians can be the most challenging part of my job. Healthcare has become something that has been dictated by payers and not by what is best for the patient from the physician's viewpoint. Compensation is not always paid by the complexity or the time spent with the patient, and reimbursement will never compensate the time you've provided to the patient. This concept is difficult for some physicians to understand if they cannot look at it from a business perspective as well from a provider's perspective. They will always be unhappy with the outcome. Finding a middle ground and having great communication skills is essential. There's a saying I've heard, a physician by choice, but a businessman by necessity. Good luck to all of you, and the best advice I can give you is to learn all you can, be mentored, mentor others, and always listen to the spirit.
Challenges of working with and for physicians, culture. In order to successfully manage a clinic, you must first understand the culture of the clinic. The culture influences how everything gets done. The office, staff, and physicians influence that culture. One of the challenges of a manager is to work with that culture to improve the practice. This is done through working together as a collective practice team to make changes. The bureaucracy. As there are different types of physician group practices, there are as many different types of bureaucracies between managers, administrators, and physicians. The culture of the practice heavily influences the bureaucracy. Some physicians prefer to be involved in many of the business decisions of the practice, whereas some prefer to let the manager or administrator to take the reins. It is critical to establish clear decision-making practices between you and the physicians. Bureaucracy should be set up to serve physicians' needs. There is a popular analogy of the physician being of the ship. The challenges of establishing effective communication with providers. As an administrator or manager, establishing communication channels is essential to serve the provider and the office staff. The manager that is efficient at providing information to those that need to be successful. To collect accurate information, you need to be an active listener. Take interest in the tasks of your providers and office staff to collect information on how you can serve those that work around you. One of the main purposes of your role in the practice is to create and incorporate new improvements to the practice.
According to a survey done in January and February of 2013 by the Medical Group Management Association and the American College of Medical Practice Executives, the 5 biggest managerial challenges facing group practices are: number 1, dealing with rising operating costs; 2, preparing for reimbursement models that place a greater share of financial risk on the practice; 3, managing finances with the uncertainty of Medicare reimbursement rates; 4, collecting from self-pay, high deductible, and/or health savings account patients; and 5, understanding the total cost of an episode of care.
In physician group practices, the physicians have the control, making them entrepreneurs in their practices. Physicians often act independently even when working with other physicians. Managers must learn how to work with and for physicians and to be good listeners and problem solvers for the physicians in their practices.
As stated previously, most of the greatest challenges to a medical practice are related to finances. This next session explores and explains the Medicare Sustainable Growth Rate and its effect on medical practices. The Medicare Sustainable Growth Rate Formula, or SGR, was enacted under the Balanced Budget Act of 1997. The bill's aim was to balance the budget by 2002 by reducing government spending on healthcare, specifically Medicare. Through this bill, $112 billion was cut from Medicare reimbursement. The SGR formula involved 4 factors: change in physician fees, change in Medicare beneficiaries, change in the gross domestic product, and the change in cost due to new laws or regulations. This chart shows previous year's estimated SGRs. As we noted on the previous slide, there were 4 factors that were used to calculate the SGR. Of the 4, laws or regulations resulted in significant cuts to reimbursement. Knowing that medical practices would be hurt by a drastic cut in Medicare reimbursement, beginning in 2003, Congress enacted doc fixes each year, thus allowing reimbursement at the previous rate. These doc fixes were annual band-aids that Congress instituted to prevent extreme reimbursement cuts. This is a simplified explanation, of course, but hopefully it helps you see how the SGR was repeatedly calculated and then ignored. President Obama rescinded the SGR under the Medicare Access and CHIP Reauthorization Act of 2015, otherwise known as MACRA, avoiding a whopping 21% cut to Medicare physician rates. But MACRA is bigger than just ending the sustainable growth rate. Yes, it provides positive Medicare payment updates of 0.5% each year until 2019, improving physicians' motivation to continue accepting Medicare patients, but it also creates a framework to reward providers for quality care versus quantity of services under the old law. Physicians previously were reimbursed through fee-for-service Medicare plans. Under MIPS, or the Merit-Based Incentive Payment System, physicians take on risk by being reimbursed based on the value of the care they give and not just on the number of services they provide. MACRA is still relatively new legislation, so we'll be interested to see how medical practices adjust to the new focus. We've included 2 quotes about MACRA that give us insight about how the legislation should work. The first is an explanation by Andy Slavitt, former acting director of CMS. After that quote, Slavitt goes on to say that providers have the potential to earn up to a 5% lump sum bonus by participating in an advanced alternative payment model. Second, shortly after President Obama signed MACRA into law, Dr. James L. Madara stated, "Passage of this historic legislation finally brings an end to an era of uncertainty for Medicare beneficiaries and their physicians. facilitating the implementation of innovative care models that will improve care quality and lower costs. Patients will be able to get the care they need and deserve.
There are many legal terms and concepts which are associated with medical practices. Medical liability is one. It is when a patient feels there was negligence by a physician which caused an injury. Another is the anti-kickback rule. This rule was made to prevent providers from accepting any value payment to increase the amount of referrals. This could be referrals from anyone, not just physicians. Starks 1 and 2 make it illegal for physicians to refer to other physicians that they have a financial relationship with. Violation against anti-kickback and Stark laws are criminal acts which can result in fines and even prison time. False claims are claims submitted to the government for payment for something which did not happen. False claims costs add up to billions of dollars each year. Many of these claims victimize programs such as Medicaid and Medicare. Excuse me. HIPAA is an act to help protect the information of patients. Extra security measures are taken in order to make sure that each patient information is being fully protected against others.
The Medical Group Management Association, or MGMA, is a membership and advocacy group for medical group management. MGMA provides the essential education, legislative information, and data and career resources to help improve patient services and operational efficiencies. This group provides benchmarks, educational resources, legal information, and networking for its members. The MGMA represents more than 33,000 administrators and executives in 18,000 healthcare organizations, in which 385,000 physicians practice. The MGMA has been established for 90 years and is headquartered in Colorado. So MGMA members, 57% are women, 55% have a master's degree or higher, and 3,262 members are fellowship level certified with the American College of Medical Practice Executives. The body of knowledge created by the MGMA is a repository of industry knowledge for medical group managers. It is the authoritative guide to managing a medical practice. It includes 8 domains, which are human resource management, financial management, business operations, risk management, information management, organizational governance, patient care systems, and quality management. The only board certification in medical practice management is a Certified Medical Practice Executive Credential, or CMPE. Certification is administered through the American College of Medical Practice Executives, or ACMPE. The CMPE shows proficiency in the body of knowledge. In order to apply for the CMPE, one must be a member of MGMA and have at least 2 years of experience in management, 6 months of which must be in a supervisory role. Once the CMPE credential is earned, it must be maintained through continuing education. After a member earns the CMPE credential, they may work toward the highest level of distinction in medical group practice management and become a fellow in the American College of Medical Practice Executives. State affiliates of the MGMA are available in all 50 states. Each affiliate has its own website. State affiliates provide state-level networking, education, and volunteer opportunities. Because state organizations are affiliates, having state-level membership does not mean you have national-level membership, and we included the website where you can find all the state websites.
The MGMA wrote a letter to the U.S. legislative leadership to outline their position on the Patient Protection and Affordable Care Act of 2009 and the Healthcare and Education Affordability Reconciliation Act of 2010. This letter was addressed to Speaker Nancy Pelosi and Minority Leader John Boehner. This letter that is on screen you can read over, but the main points of this letter are as follows. Medicare physician reimbursement, independent payment Advisory Board, Advanced Diagnostic Imaging Services, state demonstration programs to evaluate alternatives to current medical tort litigation, limitations on Medicare, exception to the prohibition of certain physician referrals for hospitals, healthcare fraud enforcement, and administration simplifications.
How can you go about positioning yourself to become a medical group manager? The following will help you qualify for a managerial job. There are pros and cons to each. Getting a 4-year medical degree, usually this applies to nurses. They have the experience in the medical fields. This is a hard way to get qualifications, and nurses generally do not want to use their degree for managerial work when they could be helping people. Management experience. Could have a lot to offer in the way of management skills and knowledge. Lack of experience in the healthcare industry can lead to difficulties dealing with medical personnel. Getting an MBA. You'll bring lots of tools and skills to your work, but they must also include people management skills. Staying technology savvy. Healthcare and technology are becoming more mixed. Anyone who has the ability to adapt to those changes will have the advantage over those that don't. Working up through the ranks. This is good because you will be familiar with the facilities, but you will not have the formal education to go with it. This could lead to undervaluing yourself and getting undervalued by others.
So is a future in physician group practices for me. The purpose of your job is to provide and facilitate a practice that is known for quality care for the patient. When you and the providers are working together to accomplish this goal, the practice will thrive. The future of physician group practices relies on leaders and managers who are equipped with the proper training and education. Seek to always improve upon your education. The healthcare administration field is always evolving. Make sure that you are evolving along with it, so to accelerate your career. And then after this, we've listed our sources for you to take a look at. And I hope you all enjoyed our presentation on physician group practices.